Hi, I'm Dr. Glenn Iannucci. I'm a pediatric cardiologist with Children's Healthcare of Atlanta Cardiology. I am an Atlanta native and attended Georgia Tech for undergraduate, then Medical College of Georgia for medical school in Augusta, and then returned to Atlanta for pediatric residency and pediatric cardiology fellowship at Emory and stayed on with them as faculty. And I'm going to be reviewing the approach to the feigning child. I last covered this for your group of ER physicians and hospitalists a couple of years ago. So I have no real disclosures. I do have a twin brother who works for a pharmaceutical company, and unfortunately they put his face all over this website, which exists online now, so I feel like I should declare it. Thankfully, they make medications that we do not prescribe. I do receive a small amount of NIH grant money to study aortic disease. It's unclear if that will continue given the current political climate. I usually start by showing this video because I think this provides kind of a perspective that a lot of families and individuals in the community have.
We have team coverage tonight, beginning with Sports Director Jack Doles, who is live in Fenville. Jack?
Susie, they have run the gamut of emotions here in Fenville over the last 18 hours. It started with elation, turned to shock, and now this community grieves. Wes Leonard's last act on this earth was to win a game for his team. Wes Leonard put his team on his shoulders in last night's regular season finale. A win over Bridgman, and they'd finished the regular season with a perfect 20-0 record, with the game tied at 55 in overtime. Leonard got the ball near the top of the key, streaked down the lane, and laid it in for a 57-55 lead. The fans went nuts, but there were 20 seconds left. Fenville got the stop it needed, and the celebration was underway. It looked like a storybook ending to a perfect season. The players lifted Leonard in the air. But shortly after the team huddled up, Leonard collapsed. He was rushed to the Holland Hospital and pronounced dead a little before 11 o'clock.
So it's unclear from reviewing kind of online reports if this patient had hypertrophic cardiomyopathy or perhaps dilated cardiomyopathy. But that ends up being one of the number one causes of sudden death, particularly in athletes. One of the other causes is a patient that I took care of as a fellow. So this was a 15-year-old, similarly was playing basketball, kind of ran down the court, clutched his chest, and then collapsed. Thankfully, there was an ER physician in the stands that day, got up, provided CPR, and the patient recovered. And by the time I'm seeing him, he's sitting up talking to me like nothing happened, asking me if he can play in his game in a couple of days. When something like that happens, we really do a much more extensive workup. And when we did that, this is what we found. This is an ultrasound image, and this is the aorta just above the aortic valve. That's the pulmonary valve. And then here we can see an unusual color signal in between the two arteries, and that's blood flow coming from the right side of the aorta between those two arteries into the left coronary artery distribution. This is consistent with an anomalous coronary artery origin. On his CT scan, you can see it a little more plainly. So here we've labeled the right ventricle, the aorta, and the pulmonary artery. In the typical course of the coronary arteries, I've shown in orange. And here, in this case, the red picture shows that this coronary comes off in an unusual position, kind of an angulated orifice that we think contributes to this presentation. Now, this individual, when we identify this, we are all very excited. We feel like we are wearing our superhero pajamas and, operate on this to reimplant the coronary. And then after recovery from surgery, he's allowed to resume playing sports. So this is kind of a good story compared to the other one. Goals and objectives for this presentation are to perform an initial evaluation for a patient who presents with transient loss of consciousness, identify key red flags in the history, and know when to suspect a cardiac cause of syncope. And then we're going to touch a little bit on POTS. I kind of called it try to avoid stirring the pot there while we're in the ER. But syncope is common. In populations that are easy to study, like military recruits, it's been demonstrated to occur in 20%, medical students 39%, including me, and about 1 to 3% of all ER visits are for a chief complaint of syncope, and this is in the adult side. And it's estimated that up to 50% of individuals have at least one episode during a lifetime. I put this in blue because this is the quote or the statistic I commonly quote when I'm speaking with patients. Peak age of incidence in pediatrics is about age 15. Certainly we see folks younger than that as well. And of note, it can have a pretty profound impact on lifestyle. So these are two patients that I took care of, saw them the same week in clinic. The one on the left of the screen, or the patient right, with cardiomegaly, was a teenager who had an unbalanced AV canal defect, who was not repaired early in childhood, and then moved to the United States. And at that point, it was too late for him to be repaired. He had irreversible pulmonary hypertension and Eisenmenger syndrome, where his AV canal shunt went from right to left and resultant heart failure. So here you can see he's got a PICC line. He was also on chronic oxygen. And, he requested that I write a letter, and I had to write several to allow him to attend school. On the other side of the screen, the right side, or patient left, is a normal chest x-ray of a teenager who had recurrent syncope, who had requested that I write letters for homebound education because her symptoms were so severe she could not attend school. And this has been studied formally. So this is a paper from 2012 that looked at quality of life in these patients. And patients with recurrent syncope scored lower than those with diabetes, and similar to those who had end-stage renal disease on dialysis, and patients with structural heart disease. The perspective of the family, can often be a little different than healthcare providers. So this statement, syncope can be benign or the premonitory sign of a serious problem, including cardiac arrest, is one that you might read in a paper. And often when a parent reads this, they really see the back half of the sentence more prominently. As a healthcare provider, we run into this fairly commonly and feel much more comfortable with it. So this ends up being a little bit of a divide that we have to bridge during our evaluations. In 2017, the American College of Cardiology and American Heart Association produced guidelines for the evaluation of syncope that were later endorsed by the American Academy of Pediatrics. It's a long document. The easy button on this is that the initial evaluation should include a detailed history and physical exam in addition to an EKG. And shortly thereafter, the Canadian group released pediatric-specific guidelines, and the main difference for this was that they don't mandate an EKG necessarily. So if someone has an episode that's highly consistent with vasovagal syncope, then they might not need an EKG. From my perspective, if you have a patient that's presenting to either an emergency room or urgent care, that individual has already kind of breached a threshold level of concern that I would not overthink this. I would just do an EKG on anyone who presents in that kind of a setting. The patients where they might not need it is, known prior family history of vasovagal syncope, had a lab draw, got lightheaded, and then, it comes up on review of systems when they're seeing the pediatrician several months later, hasn't had further issues. In that setting, I don't feel strongly about getting an EKG. Their guidelines also made note of red light, yellow light, and green light symptoms. And in my mind, I think some of even the yellow light symptoms to me would be concerning enough to warrant further evaluation. So for example, palpitations just prior to syncope, to me, that's really, we need to see those individuals. So I would really just kind of think of this as either green light or red light, and I would just lump all the yellow light kind of features in with red light. You guys are well aware of this, and probably more so even than we are as cardiologists, but the differential diagnosis for syncope is broad, can include metabolic causes, neurologic causes, of course, drugs come into play in the common presenting age range as well. And then the behavioral and psychiatric episodes have ended up becoming more commonplace as well. As far as cardiac causes are concerned, we really think about it as structural causes, so cardiomyopathy or coronary artery abnormalities, or more rare conditions listed there, or electrical causes, arrhythmias, so Wolff-Parkinson-White or long QT syndrome being the more common ones. And as one of my partners, Dr. Brian Cardis, rather succinctly puts it, no education or training is needed to be correct over 97% of the time, because 97% of the time it just ends up being neurocardiogenic syncope. But really, we want to be good at that 3%. We want to identify the rare causes and prevent them from having trouble. How rare is primary cardiac syncope? This is from the group at Harvard, where they looked at their clinic population over 2.5 years, so about 1,200 patients who presented for evaluation of syncope, and they only had one that was found to have cardiac syncope. That individual had syncope on exertion, which is kind of a concerning finding. In addition, they had an abnormal resting EKG and were subsequently found to have hypertrophic cardiomyopathy. This is looking in more depth at the diagnostic approach in that algorithm. Again, they note history, physical exam, and electrocardiogram. And they report that about 40% of adults end up in a category they dubbed unexplained syncope. I think that volume is likely less on the pediatric side. When we're looking at the EKG, one of the things that we're looking at is the EKG, it's the QTC interval. And so I often call this slide the most famous slide in electrophysiology. And what this is showing us is it's showing us the distribution of the QT interval in normal individuals. And here you can see kind of that males in general in adolescence are about 10 milliseconds shorter than females. And then this other shorter and broader hump here is the distribution of the QTC interval in individuals with known long QT syndrome. And what you can see is there's an area where there's a little bit of overlap between the normal population and the disease population. All that to say that one normal EKG does not necessarily exclude this condition. If we highlight those, you can kind of see that more plainly. When looking at the EKG in the ER or urgent care, the machine will often provide a calculated QTC interval. And in most cases, that's a reasonable estimate. There are times where that can be thrown off. So certainly in our younger kids, if they're wiggling and there's baseline artifact, I would trust that less. Or in some of the older adolescents, particularly if they're anxious or nervous, their heart rate's high, sometimes that can change the T waves and make those a little blunted, and then that can affect the measurement as well. Thankfully, there's a tool you can use. This is referred to as teach the tangent, where you draw a tangent line on the back slope of the T wave, and then where that intersects with the baseline, that's the ending point of the QT interval. This is also very useful if the patient were to have a prominent U wave as well. And when they first developed this, they actually did a study where they took long QT syndrome experts, gave them a bunch of EKGs, and then they taught 25 medical students this method, and then they had them measure. And after they taught them this method, 30 minutes or something like that, they were actually as good as the long QT syndrome experts. So this is a really nice thing. It's pretty reproducible and a useful thing to kind of have in your bag of tricks. So in general, the threshold for further assessment is if the QTC is greater than 440, probably greater than 450 would be fine for adolescent females. As we noted, they tend to be about 10 milliseconds longer than their male counterparts. Causes of sudden cardiac death. So this is probably the second most famous slide in electrophysiology. So here we can see hypertrophic cardiomyopathy makes up the majority. And then if you add coronary anomalies, that ends up being well over half the kind of structural causes of sudden cardiac death. And we'll touch on this in more detail. This is a patient that I was involved in the care of. So this is a 16-year-old previously healthy male presented with dizziness, headache, and nausea. And this was his initial EKG. And we can see that there's some abnormalities on this. So looking at the rate overall is acceptable. The rhythm appears normal. Here's normal P wave before every QRS, QRS after every P. The axis looks abnormal. So here we have a downward QRS in lead 1 and also an overall downward QRS in AVF. That fails the 2 thumbs up rule. It should be upright in lead 1 and upright in AVF. And in this case, we're 2 thumbs down. So that is abnormal. So we have axis deviation. It also looks like our voltages on the left precordial leads are much lower than our right precordial voltages, which is abnormal. So this would be consistent with RVH. And then our T waves are abnormal as well. They're inverted in V5 and V6. The only time you should really have an inverted T wave in V6 is if you are a newborn. So beyond the newborn period, V6 should be upright. Additionally, if we look at the other T waves, we see we're inverted in leads 2, 3, and AVF as well. So now we have inferolateral T wave inversion, which is abnormal. A brief note about the T wave in lead 3, that can be inverted, and if that's present in isolation, then in most cases that's totally okay. Even things like a carbohydrate-rich meal can cause that T wave to be inverted. So if that's upside down, everything else is upright, you don't have to worry about this. But these T waves being inverted is concerning to me. So appropriately, the individual had lab work done, low sodium level, not terribly striking. And then the BNP was 1300. Troponin was negative. A BNP of 1300, I refer to this often as like the CRP of heart disease. You can have one where if it's very mildly elevated, perhaps that's not a big deal, right? It's like 110, the upper limit of normal is 100. That's like having a CRP of 1. Maybe it's not totally normal, but it's not too concerning. A BNP of 1300 is like having a CRP of 35. That means this patient has acute bad heart disease until someone proves they do not. This individual also had a chest x-ray completed. Here we can see that. These measurements were performed by radiology. I did not put those on this image. And they formally read this as upper limit normal cardiac size. Just kind of gestalt, it looks like it fills most of the left chest. And if you do the math on those numbers, the cardiothoracic ratio measures 63%. And the upper limit of normal would actually be 50% for anyone above age 1. If you're under age 1, up to 60% can be normal. So the chest x-ray is abnormal. The history is not particularly reassuring. We have an abnormal EKG and an abnormal BNP. So the outside ER appropriately called cardiology, and the physician assistant reviewed these findings and then discussed them with their attending, who said, well, they're 16, they need to see pediatric cardiology. Unfortunately, that at some point in communication became, well, maybe they can see him as an outpatient. So the patient was discharged. They returned later the following morning, and this is their EKG. Here we can see this was performed by Children's Transport, and unfortunately this was done after a cardiac arrest. And now we see significant ST segment changes and changes in the QRS pattern and width as well. And this is, of course, very concerning. This patient ended up being transferred to Scottish Rite. Unfortunately, they had prolonged CPR and ultimately were found to be brain dead. We were involved and we sent genetic testing. There's something called the Sudden Cardiac Death Panel now that looks at genes that are associated with arrhythmias and or cardiomyopathy. And he was found to be positive for lamin A mutation, which is associated with hypertrophic cardiomyopathy. This ended up being very important as his brother was subsequently found to carry this genetic variant and have hypertrophic cardiomyopathy as well. This is what we would see on an echo. For orientation, this is the left atrium, mitral valve, left ventricle, aortic valve. This is the interventricular septum, the LV posterior wall, and just take my word for it, these are quite thickened. Importantly, this is a disease that is progressive, so often gets worse over time. So this is that same patient 4 years later. You can see now the LV cavity compared to the wall thickness is really small. The wall thickness is massively enlarged. And my point in bringing this up is that sometimes people say, well, why don't we do echo screening to check for this? And yes, you could do that, but the challenge is you would really want to start that before people could get into trouble. So maybe you do that at age 10, but then they can develop this during adolescence. So then you would need to repeat screen them, possibly at age 14, possibly again when they complete skeletal growth. And for a test that's, over a couple $1,000s, that math really gets very expensive. So that's why it's not used for routine screening in the United States. We do try to really focus on taking a good patient and family history. Certainly symptoms that would be suggestive would be exertional chest pain or dyspnea, syncope or near syncope with activity as well. Post-exertional syncope can sometimes be associated as well. And then importantly, if they have a murmur on standing, we should always view that as abnormal. So what happens is that when we stand up, we get decreased venous return, right? We have some blood that pools in the legs. And what that does is there's less blood in this chamber, and that causes the walls to move closer together. And because of that, as the heart is pumping, then there's less room for the blood to get by the thickened heart muscle, and you get a little bit of obstruction there. And that creates typically a harsh systolic murmur at the left mid-sternal border. And, really, if it's louder with standing up, we should really be concerned about hypertrophic cardiomyopathy, or the other thing that can do that is mitral valve prolapse, which would also need to see us. We also dig into the family history a good bit. Really thinking about things that start with S, so seizures, unexplained syncope, unexplained death, SIDS, someone who knew how to swim, who drowned, single car accident, so there's no real clear reason why there was a wreck, or other unusual accidents. And then obviously if there's family history of cardiomyopathy. This is a pedigree of a patient that one of my partners saw during his training, was in seeing a pediatric patient for passing out. Kind of during activity was a little unusual, and while he was in there, the grandpa actually hit the ground, and they put an EKG on him, and he was actually in polymorphic ventricular tachycardia. So he got resuscitated, and what they ended up having was something called catecholaminergic polymorphic ventricular tachycardia, or CPVT. And that's a condition where when the heart is exposed to adrenaline, you end up getting polymorphic VTAC, and then that can cause syncope or sudden death, unfortunately. Orthostatic vital signs, we often will do these when we're seeing patients in the office. So we check a heart rate and blood pressure while lying down. When we stand up, a natural physiologic process is to release a little bit of adrenaline. So typically heart rate will increase a little bit, blood pressure may increase a little as well. And typically we reassess those vital signs after 3 minutes of standing to allow some equilibration of state. And if you have a heart rate change that's greater than 40 in pediatric patients, then that could be associated with POTS, postural orthostatic tachycardia syndrome. And the adult cut point is a measurement of 30. And, often I refer to this as a poor man's tilt test, right? This takes a couple of minutes, can be done in the office, whereas a tilt test is very expensive and really takes up a lot of time and effort. When should someone see cardiology? So if there's concerning family history, we should see them. If they have a syncopal event, that is less likely to be vasovagal in etiology. And this is an acronym that I made up that I use with families. I say, look, we want to see, someone I think has vasovagal syncope. I say, If they have another episode in these settings, I want to see them back. So if they ever have an episode without warning, they didn't feel funny, didn't get lightheaded, they just find themselves on the ground, I want to see them again, because I think about that differently. If they have an episode that results in injury, stitches, chipped tooth, broken bones, I want to see that person again. Most patients that have this, particularly after the first episode, usually know that it's coming. And if you watch them pass out, they'll actually kind of slump rather than tree fall. So usually you're not getting hurt from this. If you have an episode that starts with palpitations, this is kind of easy one. If you feel your heartbeat funny and then pass out, your heart doctor should see you. And then if you have an episode that occurs with exertion, typically when we exercise, blood pressure goes up, up, up. So you usually don't have any trouble in the midst of physical activity. When we stop exercising, blood pressure has to come down. And in some patients who have vasovagal physiology, if that blood pressure comes down quickly, then sometimes they can get lightheaded after exertion. The easiest kind of example of this is someone who's running sprints on a treadmill, gets really tired and just hits stop, with no cool down. The other times that this comes up is sometimes if you're running suicides, head up, head down, head up, head down, or doing burpees would be scenarios that could provoke this as well. And that could still be consistent with simple fainting. Other patients that should see us would be ones that have simple faint that's disruptive to life, right? There are things we can do to help those individuals, or if they have an abnormal physical exam or EKG findings. So, I can't stress enough that the history is really very important. So I got the one-line history from our intake staff. They said, yeah, it's a 10-year-old female who had a Syncope event music class. In my mind, I'm already thinking, oh yeah, they were probably standing up in choir, had their knees locked. Yeah, this is probably going to be fine. They did have a history of a VSD repair as an infant. And since they had a prior sternotomy, I'm going, it's a little different. So you think about that individual a little harder. You can go take the history and it's like, no, she wasn't standing up. She was sitting down like crisscross applesauce and listening to the music teacher play guitar with her classmates. And then there was kind of an unbraced thud where she went back and hit her head. So you're going, that's a little unusual. Let's put a monitor on you. So when we have her wear a monitor, we see this. So on this EKG, this is a single lead EKG. We see a P, QRS, T, P, QRS, T, P, QRS, T, P, and then no QRS. And then here again, we have another P and no QRS. And so she ended up having second degree or high grade heart block. And in patients who've had prior cardiac surgery, there is always a little bit of risk for this. In her case, going back and reviewing the history, her parents say, oh yeah, now that you mention it, there was a period after her surgery where she was in heart block, but thankfully we didn't need a pacemaker then. We said, well, that is true, but you do need one now. It is something we see very commonly. So this is just data from our practice where the primary complaint at the visit was syncope. And you can see that really the number of patients we've seen for this has just continued to climb over time. And in the last year, we saw over 6,000 patient visits for syncope. And that's out of about 43,000 outpatient clinic visits. So certainly something that's very common. I tried to find up-to-date data on whether or not we think the incidence of this is actually increasing, but really couldn't locate any hard evidence of that. So this is kind of the best I could do. When they come to see us, our evaluation will again include a detailed history and physical exam. We may repeat an EKG. If we can see the one they had in the ER, they bring it with them. Often we don't have to repeat it. About 38% of the folks we see will end up getting an echo. That's typically performed if they had exertional symptoms or an abnormal EKG. Only about 5.5% end up getting a Holter. Again, abnormal EKG or palpitations might direct us in that testing modality. And then only 2% get stress tests, and then very, very few get tilt tests. The reason for that is that the data on tilt testing is not very encouraging regarding its use. So there's a high false positive rate of about 40%, and then the reproducibility of the testing is actually pretty low as well. So about a third will have different results when you repeat the same test 48 hours later. And in this paper in particular, the treatment for the patients that had differing tilt test results actually ended up being the same. And so it really doesn't end up affecting management that much. It is several $1,000s. It has to be done in a hospital. And so that's really why we don't use it very often. I think in 13 years, I might have ordered 3 of these. We do see a lot of patients with neurocardiogenic syncope or vasovagal syncope, or the term I prefer, simple faint. The hallmarks of this are that it's a transient loss of consciousness with duration less than several minutes. It may be familial. I think we all recognize that this can run in families. It's interesting, there was a paper that was published recently confirming that, for what that's worth. Peak incidence is in adolescence, as we discussed. Injuries may occur but are not that common, so you should think harder about someone who had an injury with this. You can also present with seizures, but typically the lapse of consciousness precedes the convulsions, whereas in generalized tonic-clonic seizures, that onset might be simultaneous, or perhaps the contractions start before the loss of consciousness. This is termed in some of the literature convulsive syncope. I would prefer it be called syncope with convulsion, because that kind of more adequately explains what's going on. In my personal experience, this tends to be a little bit more common in patients that are not able to get flat. So, what's triggering the seizure is venous pooling, not enough blood flow getting to the brain, you pass out, you go flat, blood flow is restored to your head, you wake up. So I had a patient who was a teenager out to dinner with friends at a restaurant. She was in the middle between 2 other young ladies in the booth, and she had a syncopal episode, and because she was in the middle, she didn't get flat, and then she had convulsions or seizure activity thereafter. And that ended up just being convulsive syncope, not a seizure disorder and syncope. And then in most patients that have vasovagal syncope, usually you can elicit a prior history of positional orthostasis. You say, hey, 2 or 3 months ago, are you the type of person where if you go from lying to standing quickly, you get lightheaded or feel unsteady? Say, oh yeah, that's who I am. And you're like, okay, I think we know what's going on. There are many triggers for vasovagal syncope. I put this picture in here as a painful stimulus, so that is one that's well described. Can trigger a vagal response where you drop heart rate and then have loss of consciousness related to that. Hair braiding or hair pulling syncope is related to the fact that the vagus nerve is near the nerve that provides innervation to the scalp, and so there's a little bit of crosstalk there where if the scalp is being tugged on or stimulated, again, you can get some bradycardia associated with that and get reflex syncope from it. You can have this happen after shots. It was kind of a big deal with Gardasil for a little while, but I believe they changed the formulation of that shot to make it a little less noxious. And obviously it's being given to the adolescent crowd, which might have increased the risk for that. Micturition syncope is something that's described in books, is a little more common in the older population, particularly older males that have prostate challenges that may have to strain with urination. Blood draws, about 16 in 10,000 in the pediatric crowd, like when having blood work done in the pediatrician office, so more common than vaccines. Church syncope, kind of usual precipitating factors there, kind of going from sitting to standing or kneeling to standing, maybe legs locked, singing, hot environment often. Yawn and stretch syncope. With stretching, one of the mechanisms is that, particularly if you put your head back, sometimes that can put pressure on the carotids, not unlike a carotid massage, causing a reflex bradycardia and then fall in heart rate and blood pressure, causing syncope. Stretch also, or yawn rather, actually is related to changes in the intrathoracic pressure, which can be a trigger as well. These are my kids, or 3 of them. The 4th one didn't make it, but in the slideshow. This is Joseph. He's now 17, and that one, she's now 14. So they have been subjected to being placed in my slideshow for several years at this point. This is another patient that I saw. So this is a 13-year-old female, palpitations, clear history of orthostatic intolerance. Because of the palpitations, I put a monitor on her. She also had migraines, and this was the monitor that came back to me. And here we see kind of regular rhythm, and then kind of, an interruption in the heart rate there. And then on the next tracing, we see, goodness gracious, kind of pretty prolonged flat lines with some real heartbeats in between, which suggests that it's not like, oh, the monitor just fell off. And interestingly enough, this was not marked by the patient, which was confusing. So called the family and said, hey, what was going on at 9:12 on this day? And they said, oh gosh, that was when we had that bad episode when we went to the neurology office. We were getting an injection and she passed out. And so this is what's actually happening when you get that strong vagal stimulus. You can actually get kind of a prolonged pause is what we call this, not brief asystole. This is another patient that I took care of recently, 17-year-old guy, competitive lacrosse player, long-standing clear history of vasovagal syncope. Getting labs done, gets lightheaded, passed out, was seen by an adult neurologist who ordered every test. Echo, extended monitor, tilt test, EKG, EEG, MRI, and then this is what came back on his monitor. Here we see multiple P waves with no associated QRS. So this is high-grade second-degree heart block. And again, interestingly, this was not triggered by the patient. And if you look at this bottom tracing, this tracing was at 117, right? Like even a 17-year-old usually be awake by that point. So he was having numerous episodes of this. And ultimately, he ended up getting a pacemaker. It's important to note, that some of this was asymptomatic, and it just is a little bit of a reminder to be wary of the well-adjusted stoic patient, right? They might underreport symptoms. In this case, his prior history of vasovagal syncope was actually a little misleading. But if you go back and ask him, hey, why did you come back at this time? The mom says, well, he had an episode, was standing in the kitchen, went down and hit his eyebrow on the countertop, So that's an unbraced fall in someone with known vasovagal syncope. So he kind of would have failed that wipe test, So I'd like to think that I would have caught him on history that way. So we're going to move on to touch briefly on complicated syncope patients. So I put this slide in because, there ends up being kind of a common presentation where often there ends up being an insult, whether that's an illness or an injury, something that kind of takes them out of their usual routine, which may or may not involve sports. And then, really they spend a bunch of time at home, maybe a bunch of time in bed, and then that leads to deconditioning, and then sometimes it's really hard for them to get back to life and back to moving again. There's kind of clear evidence of autonomic dysfunction following COVID. Certainly that was seen in the early rounds. Definitely long-lasting kind of fatigue after Epstein-Barr as well. And this history is one that ends up repeating itself in our offices. This is a slide just showing the autonomic nervous system, just to touch on the fact that really we have kind of a gas pedal, the sympathetic nervous system, fight or flight, and a brake pedal, parasympathetic, rest and digest. And the way our body drives our car is it's making minor manipulations to both pedals at the same time, all the time. As most teenagers know, usually you don't drive a car with both feet at the same time because it can be hard on the engine. And so sometimes when you have autonomic nervous system dysfunction, we can end up having some challenges between inappropriate braking or inappropriate gas, and that can lead to some of the symptoms. And that's often the way I explain it to families. We do know from studying COVID that autonomic dysfunction is real and happens following COVID. This was from a 2022 article talking about kind of return to activity after COVID. And they also highlighted that there often is a downward spiral, and I put of despair in parentheses up here, but again, this is kind of a pattern that ends up repeating. Get early symptoms, they feel bad with exercise, might be lightheaded. That makes them decrease their activity level, and or they might be sick enough that they're resting in bed. Then they get cardiovascular deconditioning, worsening of their symptoms, don't want to exercise, and you end up in this like kind of bad spiral where you just feel worse. And when I'm reviewing this with patients, I often liken it to Newton's first law of motion, which a lot of people may recall more fondly as the law of inertia. And so what that is that objects that are at rest tend to remain at rest unless acted on by an outside force. Similarly, those that are in motion remain in motion. And I think that concept is unfortunately somewhat applicable to patients, right? The ones that are in motion tend to remain in motion and tend to do well, right? For those that are exercising frequently, exercise is easy. They feel good doing it. And for those that come to rest, sometimes it can be really hard to get them moving again. So I made this Glenn's law of people. As Sir Isaac Newton demonstrated, you're not allowed to have laws unless you have awesome hair. So I borrowed some hair from the 1990s rock glam band Europe. Maybe they were 80s, I guess. But this kind of concept was utilized by the American College of Cardiology again as they started stressing return to activity for those who had COVID. What they really pointed out was that this needs to be a gradual process for those with kind of the long COVID type of symptoms. And really you start out with, really a small amount of activity. So 5 to 7 minutes a day of physical activity for a week. And then the next week you go to 8 minutes. And then the next week, 9 minutes. And so then over the course of several months, you gradually work up to, a more reasonable 30-minute exercise interval. For patients that are having a lot of trouble, recumbent bike or rowing tend to be good because you're not upright for those things. Swimming is also fantastic for this. I will say for most kids, this is likely way too gradual. But I do kind of share this with patients to say, hey, look, I know you're used to, running 2 miles in 20 minutes or 2 miles in 12 minutes, whatever it is. We don't need to get to that right away, and we need you to kind of get back to that gradually. And because what often happens is the ones that have been, sporty before will try to go out and do that, and then they'll feel terrible for the next 2 or 3 days, and then they're kind of back in bed. So we need that to be a more gradual process. So in general, the way I approach these patients, and by these patients, I mean those with kind of more complicated syncope, is I think about this existing along a spectrum. So on one end of the spectrum, there are patients that have neurocardiogenic syncope or simple faint. And then on the furthest end of the spectrum are patients who have POTS or postural orthostatic tachycardia syndrome. And, I go through this with families and, to fulfill diagnostic criteria for POTS, you really need a heart rate change of greater than 40 on orthostatic vital signs, and then kind of more long-standing symptoms. And that's one of the reasons why I would say I would discourage kind of, handing that diagnosis to folks in the ER, just because it ends up being a really complicated discussion. And sometimes folks will go online and then they're like, oh my gosh, we need to order a wheelchair, we need to start getting IV fluids all the time. And that really is just a very small subset of patients that end up kind of in that category. The other thing that can be very confusing is that if you look up POTS, it lists every symptom imaginable that could be potentially related. Headaches, they're from your POTS. I have abdominal pain, also your POTS. I have diarrhea, that's POTS. Constipation, also your POTS. Wait, how does that work? And so I think it can be really confusing to patients. So anyway, that's why I try to reserve that diagnosis. On the other hand would be, this is one of my children, and she kind of presented, in the like 10 to 12-year-old age range with getting lightheaded while altar serving, because we went ahead and signed our kids up to AlterServe, even though their dad has a history of vasovagal syncope. And rather conveniently, I chose to marry someone who has low resting blood pressure. Oops, sorry, kids. So 3 of our 4 have passed out, and our 4th is 8. She just needs a little more time to ripen, probably. So, but for this one of our children in particular, she really does fine with exertion, can play basketball, do everything like normal. Her symptoms are annoying, but not overly disruptive to life. We do have to, manage her symptoms with aggressive hydration and salt supplements. And then we're mindful about that. If we know she's going to have increased losses, several basketball games in a day, we might do more, that type of thing. And so a lot of the patients will fall into this category, probably about 90%, with only about 10% ending up needing medication. And I do stress to families that not to get hung up on the name, that regardless of which name we use, the treatment ends up being identical. Typically, the treatment recommendations would be to start with non-pharmacologic measures, 72 to 128 ounces of fluids, the majority of which should be water. People will often ask, well, how much should I drink? What number? And then they'll say, well, where did you get that number from? And I'd say, well, we made it up. And because truthfully, that number can be very different for different people, even if they're the same size. I'm naturally gifted at sweating. It's one of my powers. So I might need a lot more fluids than someone else who doesn't sweat quite as much. So I often will give people a target to start with, and then I let them know, look, really what we're aiming for is clear urine multiple times per day. That will give us a sense that we're doing enough with fluids. Then we tell them to increase their sodium intake. Sometimes if you just leave it at that, they might eat a few more pretzels a day, and that might be all they do. So I've started trying to tell people, hey, look, we're looking for 1,000 to 2,000 milligrams extra. So whether that's soup, soy sauce, liquid IV, Element, salt sticks, Vitacium pills, there's all kind of supplements out there. It doesn't really matter what it is, but that's just to give them a ballpark. Some of the adult studies recommend a total daily intake of like 8 grams per day. And then we know routine exercise is helpful. I've kind of covered that a little bit already. For those that have ongoing significant symptoms, then we would consider medication. And there's no awesome data that says, hey, for this patient, you should use this, for this, you should use that. So this ends up being a lot like migraine management, where it ends up being a lot of trial and error. And we try to pick the medication that's most directly going to target their worst symptoms and have the least side effects. So if their primary complaint of dizziness is dizziness or orthostasis, then we'll often use things that would expand the blood volume like Florinef or DDAVP. Or midodrine, which reduces peripheral vasodilatation, can raise blood pressure that way. The midodrine is notable that 30% of folks will get goosebumps when they take it. So I do warn people about that. So, it's unusual to have something where 30% of people get a side effect. So it's kind of fun that way. If their primary complaint is really palpitations or tachycardia, that's the group of patients that tends to respond well to beta blockers as initial therapy. I tend not to use that as primary therapy for those that are lightheaded because it can adversely affect blood pressure. And then for those that are not tolerant of beta blockers, ivabradine, which is a medicine that's a little cleaner, it acts directly on cardiac myocytes to reduce the rate of depolarization and doesn't have any effect on blood pressure. So it's kind of a nice medicine that way. There's also no associated fatigue or risk of depression or adverse effects on asthma. That's why I kind of describe it as being cleaner. If their main complaints are GI dysfunction, early satiety, nausea after eating small amounts, constipation, then pyridostigmine or Mestinon can be helpful in that patient group. It's one I use occasionally, so I have a little less experience with it, but that's been the patient group that seems to get the most benefit from it. Other things to consider in the complex patients is whether or not they could have a psychogenic etiology. So this certainly, as we've seen more mental health issues come about, certainly we've seen this more frequently as well. This kind of paper looked at several studies, and kind of the takeaway points from that were that data suggests it might be a psychogenic source if there's a prolonged duration of loss of consciousness or a high frequency of events. And they describe that as being more than two times a day. And I think that's useful to bear in mind, particularly if you have a patient who just really doesn't seem to be responding to kind of the standard measures. This is a patient that I took care of who had sent me documented evidence of all of her syncopal events. And you can see some of the other things, a lot of her episodes were kind of atypical. So if we look at this one in the bottom right, we can see she's actually remained unconscious, kind of upside down and backwards at the top of the stairs with her head well below her heart. And physiologically, really, if one were to lose consciousness and land in that position, we would expect rapid return of consciousness. Again, kind of passing out with the knees in this unusually flexed position, a little atypical. Here's an episode where her head is right next to some molding. So she was passing out like 20 times a day and never getting injured, thank goodness. And so, this was a patient, that really kind of fit that picture, really didn't respond well to routine therapy. One of the questions that came up when I was giving this lecture to your group live was, how do you manage these patients? And, in truth, I think it's really, really hard to make that diagnosis in the ER. You don't have an established relationship with the patient. I often start by including that anxiety can make these symptoms worse, like in the very beginning when I meet people. And then I say, look, we don't have monitors that show us anxiety. We do have things that help us identify if it's a cardiac cause. And so, we're very good at identifying that. And then, if we're getting further down the road, then maybe we might need to think about that. So I open that door at the beginning before jumping through it. And then often folks are more receptive to that kind of over time after they know I'm like trying to help them and not, just trying to get them on to the next appointment of the day. As far as treatment for this is concerned, this I really think is not unlike pseudo seizures, right? The most common population to have pseudo seizures are those who have a seizure disorder at baseline. And I think for most of the patients that have this, they do have vasovagal syncope and probably ongoing presyncope. But I think this ends up being an adverse coping strategy. So they, start to feel bad or lightheaded and then go into this. And so by that token, a lot of times if we treat their underlying lightheadedness or presyncope, then that kind of helps them to recover and maybe they have less of this. And I often will explain that and say, look, I'm not sure how much of it is anxiety, but perhaps if we do these things, then that can reduce the overall burden. And that tends to work reasonably well. So if you remember nothing else, I would say history is critical to identifying the cause. Super important. Bearing that in mind, right, if there's a patient where our ability to obtain history is limited, whether they have developmental delays or perhaps, they're on the younger end of the spectrum, 7, 8 years old, and you're not sure how much you can trust it. Those are patients where I would think a little bit more about, extra workup than a different setting. We covered that the wipe signs are a little bit more suggestive of a non-vasovagal etiology, so that's what I would use to kind of raise the suspicion. And then I would say you want to try to make people earn the diagnosis of POTS. I think it's really hard to get into all that in the ER, and certainly very reasonable to send them to us or neurology or whoever, and we can help with that. One other question that came up when I gave this presentation live was what patients would we recommend inpatient hospitalization for? And in general, I really think of syncope as an outpatient problem. Those that would warrant inpatient evaluation would be, gosh, the episodes are super frequent. I think if I send this person home, they're going to have like a bunch more before they can even get in to see somebody. In cardiology, we can get them in really pretty quick. So that might be someone you keep in-house. Certainly anyone that's required kind of CPR in the field, I would not overthink that. I would say, hey, we really, need to be sure that this person's okay before they're going home. A lot of times they may be sitting up looking at you and you're going, well, did they really need it? Again, that patient that I had with the abnormal coronary, he really looked perfectly well by the time I saw him. So those would be the ones that I would suggest kind of a more urgent or inpatient evaluation. I neglected to put my email address on this slide, so my email is my last name and then g@kidsheart.com. That's IANNUCCIG@kidsheart.com. Please feel free to reach out if you have any questions, and hopefully this recording has worked, because this is now the second time I did it, but we will see.